But whereas Alzheimer's disease began with early memory failure, in dementia with Lewy bodies, we're looking more at executive dysfunction and visual spatial problems early on, earlier than the presentation for memory problems. Other features that can help you make a differential diagnosis in terms of core clinical features, there is known to be fluctuating cognition. And what that means is that there are some days for a person with dementia with Lewy bodies where they seem completely normal for their own baseline. They're functioning very well. And the next day they'll seem incredibly confused and very impaired. That can be something that's difficult to quantify. And certainly people with Alzheimer's disease have good days and bad days, but the fluctuation is much more significant in dementia with Lewy bodies. And in the next slide, I'll give you a few questions that you can use to evaluate this feature of dementia with Lewy bodies. There's another cognitive screener that's become very common. So it's very easy to use. It's very, very quick. And essentially what you ask the person to do is to draw the face of a clock, put in all the numbers, and set the hands of the clock to 10 after 11. There are a variety of scoring systems available for the clock drawing test. A very simple clinical scoring system uses 4 points, 1 point for a complete circle, another point for including all the numbers 1 through 12, putting them in another point is for putting them in the correct place. So the 1s, 2s, and 3s have to be where those should be all the way around the clock, and they have to put in the correct time. And within this scoring system, the cut score that people use often is less than 3 indicates a failed screen. Now it's a pretty simple test, dementia diagnosis. We want to avoid frustration, fatigue, and withdrawal from the process. Certainly we want to hit the key areas of cognitive functioning, but we want to be sensitive to their engagement in the testing process. We simply don't need to do 8 hours of cognitive testing to make a dementia diagnosis. After we've administered tests, we do scoring in comparison to norms, which we'll talk about shortly. We'll review other diagnostic information, neuroimaging, perhaps other lab reports, write a report, give feedback, and perhaps even engage in care planning process. So we're going to look at performance in a number of key domains that are relevant to broad cognitive functioning, but also to making a dementia or MCI diagnosis. Many of these have been touched on when we talked about the various forms of Alzheimer's disease and depression. On top of it, it makes the Alzheimer's disease and functioning worse. So when you have dementia, you function at a lower level than you used to, and when you add depression on top of that, it brings functioning down even lower. So people with depression and dementia have greater probability of delusions, combativeness. They're more limited in terms of activities of daily living. They're more restless, agitated. They're more likely to be discharged from assisted living into a higher level of care, that is nursing home placement. And so one of the things to think about in terms of the broad realm of dementia-related practice is when we think about the limited effectiveness of Alzheimer's medications, one of the things that we can really do to help people with dementia is to detect previously undetected depression and to prescribe effective treatment of that depression.